providers, especially the earlier detection, and then make you aware. Oh, look like you're awfully healthy. Why your score that low? And then we can deep dive the causes for underlying comorbidities, and we can have from a prevention standpoint, not only the
Yes.
treatment standpoint, and then, like you said, follow up. If we find out that underlying comorbidity and a cause related to cognitive, decline, we can treat it. We can treat that, and then follow up. Oh, this is really the cause of your cognitive decline. Now we
Yeah.
stop and then we reverse. So that's not only is assessment tool, is a part of the your, as I call it, surrogate. It's a surrogate,
Yes.
is a constant, give you a tool, and then to have entire process of a healthcare pathway for each patient, using the cognitive assessment as a surrogate. Yeah.
Yes. Love it. The
Mhm.
Yep, this device, because I've done lots of MMSE testing on
Mhm.
patients
Yeah.
in clinical practice and clinical trial, right? It's one of our standards.
Yes.
And the problem is the patient learns the test. And so if I were to do it again, they would come back and they're like, okay, I already memorized how to subtract 7 from 100.
Hmm.
Or I already remember what the 3 words you're going to ask me, right? Apple, table, penny, right? They already have it
Right.
memorized the second time.
Right.
And so it makes the test kind of inaccurate the
Hmm.
second time.
Right.
Uh, CogniView prevents that memorization, right?
Correct. Cognitive view. I'm glad you pointed that out. And we have 10 tests, 6 domains, and 2 performance parameters. And then the first 2 tests, which is visual test, and then the visual acuity, and then motor test, that's not contributed to your score, but give you a calibration. The
Yes.
computer will calibrate your personalized information,
Yes.
you know, into the computer, and then to
Mm,
adjust when you do the test, the computer will adjust how to assess your domains. So each patient's each time there will be a different calibration, a different information into the computer, and the computer will recognize this, and they give you a new, fresh set of pattern. So there's no learning,
that's
there's no memorize, and every
memorizing.
single thing to you is a new test. Yes.
I love it. Do you know if this test is being implemented as part of and this is more of a clinical question, if you know if this test is being implemented as part of like an annual wellness exam. I know an annual wellness exam, part of that component is a memory assessment. I don't know if Cleveland Clinic or USC or other locations actually is doing CogniView as part of their annual wellness, or if they're doing it
Not
short.
yet, but there are several other uh, entities are talking to us and try to build that into an annual wellness. And they call the 6 vital sign.
Yes.
We have 5 vital signs. They kind
Yeah.
of temperature, blood, and blah blah blah. So they
Pain.
they call this a 6 vital sign. So
Yes.
yeah, once we we have that campaign with several collaborators, and then doing that. Yeah, that's one of our goals.
Yes.
Is really underway. Yeah.
Oh, yes, this should be the sixth vital sign.
Hmm.
Definitely. It is a vital sign that's always missed.
Hmm.
And it explains why in Orange County,
Yeah.
Alzheimer's is the
Hmm.
number 3 cause of death.
Right.
And because this vital sign is missed all the time, we are
Yeah.
not looking for it. And the part of the problem is patients think that memory loss is normal when you're older, and it's just it's a general perception that yes, I have memory loss, and of course I have memory loss, I'm older, right? I'm getting old. And the problem is the doctor thinks the same way, right? It's like, of course forget
Mm-hmm.
it. You're in your 70s, your 80s, your 90s,
Yeah.
and we need to change that mindset because memory loss, especially progressive memory loss over time, is
Mm-hmm.
not a normal thing.
Mm-hmm.
It's not a normal thing. We cannot assume that it's just because you're older.
Right.
We know that there are people who live in different parts of the world who who get as old as Americans do, who live as long as Americans do, without Alzheimer's being at the top of their conditions.
Correct. Totally agree. And a neurodegenerative, process is oftenly, you know, been recognized as a definitive, right? It's not definitive. It's really neurodegenerative. It's a pathological process, and then if you accept that as a necessity, is is always that way. So the medication or medicine is nowhere to go. So,
Yep.
all these years, the pharmaceutical device and the biomedical industry, and then and they carry a mentality as a treating the disease. So now is the time, is 21st century. We have to be aware that the prevention is equally important. So yeah, I totally echo your message, Dr. Trent. Um, Alzheimer dementia is preventable if your awareness and is across the board. And then, so U.S. is a leading country for that. We have almost 6 million diagnosis. In 2050, it's going to be triple and quadruple this number. We got to slow that down. I think we could, along with all this assessment, diagnostic, and the prevention mindset altogether across the board. Yeah,
I love what you say because we cannot prevent what we cannot detect.
correct.
And and so we need to detect cognitive decline, memory loss early in the stage of
Hmm.
this process,
Right.
in order to implement. I mean, nothing's 100% obviously preventable, but there's data out there showing that there's lifestyle activities we can do. There's diet, nutrition, exercise, brain exercise, physical
Hmm.
exercise, getting enough sleep, all these different modalities in life that we can implement without taking an extra pill to to improve our brain health. uh,
Correct.
but you won't be able to implement this unless you actually look for the problem, to catch the problem early, for these for these lifestyle implementation and things of that sort, with that. So very
Absolutely.
important. Yeah, it beats
Yeah,
taking a pill after the fact, right? After the diagnosis.
that's right. Yeah, and you know, um, yeah, American is really into it to put large investment and the long time development to go through a blockbuster drug. But yeah, what you just said is equally crucial and important for the message to deliver in the general population. The mental health or brain health is really the top, if not the only thing, but the top few things that you have to care. And then the brain health access. Access. The access accesses. So to align with with the general healthcare provider, um, and then to change your lifestyle and the mindset, and then to get into the prevention. Yeah.
Definitely. Yeah, you're right. We focus always, our healthcare system is focused on making a diagnosis and prescribing a pill.
Hmm.
Uh, it's, it's, it needs to be changed, right? I have patients come to us on a regular basis. In the field of clinical trial, it's about Alzheimer's plaque, how to find it and how to get rid of it, right?
Hmm.
How to find Alzheimer's plaque, right? Through PET scans, through all these other testing, and how to get rid of the plaque is what we do in the field of pharma. But we need to go a step before that. How does plaque form, and how do you prevent that?
Hmm.
And that is where CogniView plays a big role, right? How do you even detect that it's a problem in the first place? And unless we're testing our patients on a at least an annual basis, we don't catch the problem early enough.
Right.
And
Right.
uh, and sad to say that in the healthcare community, most of the time, by the time our patient is given the diagnosis of Alzheimer's, many of these patients are already at the moderate stage of the disease.
Hmm.
And we miss the entire mild stage of Alzheimer's, because during the mild stage, the patient thinks it's normal to be forgetful, and the doctor thinks it's normal too, so nobody brings it up
Hmm.
because they think it's just getting older. And so we miss years and years of the mild stage, where we can implement all these strategies with nutrition and with health and with exercise.
Hmm.
uh, and it gets, and unfortunately, I mean, who wants to be diagnosed at the moderate stage, right? You
Correct.
miss a lot of opportunities with that. And
Absolutely. Yeah. Yeah. You introduced in a very, very quick point. Um, Dementia is not Alzheimer, but Alzheimer causes about 80% dementia. Um,
wow.
yeah. So, and then the dementia is a symptoms consortium, that's a cognitive impairment, right? So detection, early diagnosis is the key. And then before those plaque is formed, can we
Yes.
can we prevent that? There's nobody knows that, but it seems like early detection awareness is the key, and then we could do something to prevent that. I,
That's okay.
well, yeah. So, Dr. Trinh, you can comment that, and Alzheimer is really the diagnosis. You have to find out in the blood. There are two major type of a protein called tau protein and amyloid plaque, amyloid beta um, protein. If you have that, and then the check on the past scan, and there is a amyloid plaque blockage on your diagnosis and with Alzheimer, along with the dementia symptoms. If you don't have that, but you do have a memory loss, you do have executive function impairment, naming language and delayed recall, abstraction, and any others. So that's definitely the dementia. So
Yeah. So this is a test of cognitive function, which includes memory loss testing. So this is more to look for the general memory loss, Paul. And then if there's memory loss, from there we dig deeper. Is this Alzheimer's related memory loss? Is this memory loss related to other reasons, like depression related memory loss, or hypothyroidism, or vitamin B12 deficiency, right? Or medication side effect memory loss. So this is the initial assessment, just to look for any cognitive problem that needs to, be evaluated further. This is a screening test to look for that.
So, what is the determination if you have Alzheimer's? It's still just anecdotal, or you rule everything else out?
It used to
well,
be,
go ahead. Yeah. Okay.
yeah, it used to be more of a a guess, but it's less of a guess now. Yeah, we now look specifically for the presence of the amyloid plaque, right? That Alzheimer's plaque, and we can look at it. We can look for it through a spinal tap, CSF fluid. We can look through it through a brain scan. There are some laboratory blood work being evaluated in clinical research now. Yeah.
Okay. All right. Well, how do we find out more about this? And then, what comes next? Is there anything beyond this?
Well, what comes next, in terms of this, we're talking about the cognitive assessment, right? Today, we're not talking about treatment of dementia and Alzheimer. So that has to be, Dr. Trinh and I has to be becoming a routine, like a vital signs. That's kind of a screening type of standard. So so that's why, yesterday we had a presentation. I said, paradigm shift. So gold standard need to be reformed, and we should be on the part of the vital signs. We talk about this as 6 vital signs, and then should be implemented into the healthcare provider, and as a baseline screening. And we should get the people as early as possible to get the cognitive screening to see whether there's a trend or any signal that you have early mild cognitive impairment. And then we can find out what the modality and the cause and any comorbidities underlying disease, and then start to prevent while mild treated, and then to prevent patients to slow down their progress if they do have the early cause of the dementia. Second is that the legislature need to be changed, and from the national level, regulation at the national level. So along with this wild recognition of the medical society, that the legislature should put that into the gold standard, and that's why I said that the paradigm shift. And then once that, a lot of maneuver need to be follow up, like a reimbursement, schedule a new practice time for all across the medical societies, to give the healthcare provider a time to assess very carefully about the patient's cognitive function.
So you mentioned legislative changes. I don't know what those would be. What would you like to see on a federal level or a state level to?
Yeah, so for, directly related to Medicare, Medicaid, and CMS, and they should.
What, I don't know what CMS is.
CMS is a Center of Medical Services. Yeah.
Okay.
Medicare. Yes.
Yeah. That's Medicare, Medicaid. That's I think this is a same level of FDA.
Yes.
But what would you like them to change? I don't know what you throw that out there. I'm trying to wonder.
Well, yeah. So,
you got some people who write letters. If we know what to write letters for.
We like to see this will be on the reimbursement list once it's becoming a standard practices. Okay. So, and then whatever and whenever you use this assessment to give patients on their baseline and on their routine
so right
visits.
now, if a doctor buys this device this device, they don't get reimbursed from Medicare for the cost of that or for the use of it?
We have limited reimbursement. We have some code already issued.
Yeah, everybody's got to get a code that the doctor can put in and said, I did this. Right?
Certain circumstances, not across the board. Yeah.
Yes, that's great.
And what?
I think Medicare did send a letter to every physician, at least the primary care physicians, within the last few months, promoting more cognitive testing and assessments, and asking doctors to do more cognitive assessment. It's there is a specific code to create a cognitive assessment and care plan that's as connected with these cognitive assessment, and Medicare did promote that in a letter to all the doctors.
And is that new? Is that a new direction for them here?
It's a new emphasis. It's there's been a code that's been there, but the Medicare is realizing that Alzheimer's is going to break the bank.
Yeah.
It's going to break the Medicare bank and budget. If we do not detect early and try to bend the curve.
You said that, and I've read that, and particularly after this drug came out. Now, part of it was in response to the drug. If they give this to everybody who shows cognitive decline without truly understanding whether they have Alzheimer's or whether there's a specific subset of people with Alzheimer's that this might benefit at this high dosage level that they will give this out. If they don't determine that and doctors pass it out to everybody, that $56,000 or whatever part of it they're going to cover, that could break the bank. And you're saying with or without that problem, Alzheimer's itself, the fact that you've got all these people in decline, and then what? All the other things that happen because of that?
Yep. The decline in health that is associated with the progression of Alzheimer's. If we don't detect this problem early and make a difference or bend the curve, the number of patients that will be getting this diagnosis, it's going to triple in the next, by 2050, I believe.
Is that just because we're getting older and more apt to have cognitive decline?
I can't blame it all on age, Paul, because there are folks in other countries who get just as old as Americans do without Alzheimer's.
Like where, like the Asian countries, Japan or something or whatever?
Yeah, there are a number of locations around the world. It kind of goes along with the longevity situation. These blue zones around the world where people live to 100 years old, and they live to 100 years old pretty healthy. Yeah. Without,
supposedly up in the Ural Mountains because they eat yogurt or something, or there's Asian countries because they eat fish diets or something. I don't know, something.
Yeah. So it's not all just aging, but we do have the American diet, which is not a good diet. It is a pro-inflammatory diet.
But it tastes good. Burgers and fries taste good. Come on.
I totally hear you. And so, so I do look down on all burgers with one exception, which is In-N-Out Burger.
That one you find a little
Yeah. That one's physician approved.
Oh, great.
I like this physician here. In-N-Out Burger with, chopped jalapenos. And then the grilled onions on it. It's, that's the exception, but otherwise, we have a lifestyle in the U.S. that promotes inflammation, promotes diabetes, obesity, and Alzheimer's. And Medicare sees this. It sees that an Alzheimer's patient takes up a lot more Medicare resources than a non-Alzheimer's patient because of the decline of health, right? So they get hospitalized more.
They don't eat, they don't sleep, they don't do things, they forget to take their pills, on and on and on. If you're not in charge of your full faculties here, you're not going to walk, you're not going to be social, you're not going to do anything. All of it. I saw that in my mother's case. We've talked about this many times. My mother had Parkinson's, but out of that, she developed dementia. And I don't know, was it Alzheimer's, whatever. It doesn't matter to categorize it anymore. There's nothing that anybody could do about it. And she, as her mind declined, her body declined with it rapidly. And I don't know which came first, the body or the mind. But I know that as her body shook, her fears and her mental impairment grew, and all of a sudden she got sick. Everything affected her. A little cold would knock her out. She wouldn't walk, she wouldn't eat, she wouldn't talk, she wouldn't do anything, and it was a very dramatic decline as her mind declined.
Yeah, mind decline is so one of the major pathological symptoms of Alzheimer, but Alzheimer now is ranked as number six. The the deaths in U.S. And becoming the world number 6. The why the Alzheimer has so much higher the death rate is just like you said, Paul. That's once your mind declined, and so the cause of Alzheimer, this is a plaque, right? It's an amyloid plaque, and block all the neurons in the neurotransmission. As you get block all the neurons, neurotransmission, your blood circulation, your respiratory system, and your all the neural central nervous system, and then all the digesting and endocrinology system, so all slow down, all impaired. And then once you get the threshold passed, you're gone.
That's interesting, because I never think of your mind affecting your digestive system. You rattle off 2 or 3 others here, that my mind doesn't control my body, but I guess it does in some sense.
Yeah, central nervous system controls everything. It's control your sleep, control your
digestion, your everything.
Yeah,
your
digestion, everything. Yeah.
So if this is such a priority, why isn't everybody got one of these things already? What's holding it back? And whatever else comes next, as you talked about, other things, other therapies, treatments, assessments, other sorts of things. Is this the first? Are we going to see a flood of stuff? Or is there, I guess I'm trying to get on, I'm not trying to be tough on doctors, but you said it all. The doctors only got 15, 20, 30 minutes to do this whole thing. Their practice is set up that way. Their reimbursement is set up that way. And so they rapidly go through things, and they go through checklists, and I'll let you tell I made my visual assessment. We look at your labs. I count everything on the labs. I see this, take this pill, do this. And then maybe I ask you a question or two that sort of determines, are you still there? But there's very little dialogue or discussion. It used to drive my late aunt crazy. As she declined, as she got older, the doctor would start dictating his notes as he walked into the room, because it was all based on the labs and the last report and everything. And she'd say, "Don't you want to talk to me?" "Oh, yeah. How are you?" "Yeah."
Yes. Dr. Trinh, I'll let you to answer that.
He's going to step on the landmine here. But I think therein lies a problem. If that's the way the system's set up, that's a system that's set up to read reports and to make some quick visual notes. It's not a question to ask you a 10-minute, 20-minute, 30-minute cognitive test, either to ask you or to administer a test, or even to think about it.
And that, Paul, is exactly why Alzheimer's is an epidemic.
There you go.
Because our system is not designed to even look for problems for prevention, like Alzheimer's or dementia, right?
No time.
It's not designed. There's no time. Our system is set up to make a diagnosis and to write a prescription,
yes,
right? Or send you to surgery or whatever, right? And that's the toolbox we have. And until we fix that paradigm, until we have a paradigm shift that shifts it to early detection and prevention and wellness, right? We need to shift that. We need to shift reimbursement toward that. We need to give doctors more time to do that type of testing. Unless you shift that, nothing changes, and Alzheimer's will continue to become a huge problem. But here we are at this discussion on a radio show because we want to bring awareness that this is a problem.
And what can I do? I'm helpless. I didn't design the Medicare reimbursement system. I don't know how to change it. I, as an individual patient, am always frustrated by it. I understand the pocketbook issues. We want to minimize costs. We want to make it efficient. We want to get people through the system. I get all of that. But in the process of turning it into an assembly line, have we lost the ability to talk and spend time with the patient and assess them?
Well, Paul, this has been the rising significance of this question. and it's always require top-down, bottoms-up efforts.
Right.
And then I just mentioned the legislatures, and American is a typical capitalism country. And then, we have our established system. We have our recognition about economy, and then everything is serving the country's economies. And, once you see this preventive implementation is not making the economy better, there's less interest of that. But it's improving right now. But we have to raising our voice. And Paul, you're not doing anything. You're doing anything, and you're doing something that to broadcasting this kind of a conversation.
Yeah.
To let people hear from Dr. Trinh and me, and from bottoms up, we wanted to make the case, the testimonial to prove, it is true, it is work. Once you pay attention and early detection of cognitive impairment, that will give the population a chance to prevent that further worsening about the symptoms.
Particularly as we're coming out with pills, first one in 18 years, that might do something a little bit for somebody. More pills to follow, more treatments to follow. I guess it's not really a pill, it's a shot or something.
That's only a small fraction of it, although that's making billions and billions of dollars, so what? But majority effort is focusing on prevention.
And again, as Dr. Trinh always talks about, healthy brain, there's ways to avoid this, to mitigate it. You don't have to wait till you're sick and then give me the pill, doc, and wipe out the plaque. It's not just cholesterol, and gee, I got a potential for a heart attack, so give me the pill and we'll wipe out the plaque like I do in my blood veins.
There's no such thing, Paul. There's no such things. Even this is adequatumab. It's not to wipe out the plaque, and the data still anecdotal, need to be further investigated. That's why the Office of Investigator General is involved for this, and so it's a long time to go. So we're in the meantime, I'm the boomer generation.
Yeah, me too.
Probably you too. And we gotta pay a lot of attention about
Dr. Trinh. He's I don't know where he was. He looks like he's 12 all the time here. He never looks old.
He's a baby. So
baby skin. Right.
Yeah. So this top down, bottoms up is a really
so maybe if, as my late father used to say, and he really believed this, he was just of that greatest generation, it all comes down to money. He'd always say, wait a minute, the answer is money. Now, what was the question? And whatever question you come up with, the answer for him was money. Why didn't the Catholic Church, we're Catholics, why didn't the Catholic Church allow priests to get married? It's money. It's not about anything. It's just money. Yeah.
The question is where the money goes.
Yeah. So, he would, if he were alive today and listened to this, he would just shrug and he said, why are you guys debating this? It's all about the money. So right now the doctors don't make enough. The system doesn't pay them enough. Nobody gets reimbursed enough. And so there's no money in diagnosing Alzheimer's. But if, as Dr. Trinh says, all of a sudden the cost of Medicare and taxes and everything to support this goes up, wow, we're busting the system. Suddenly everybody's going to say, well, let's save some money.
Yeah, that's right. We're wasting a lot of money. We do have money, but we don't know how to wisely allocate those money.
Apparently,
So if we do know to make sure those money, and then to put into enough on the prevention, put into enough in the early detection, put enough on the aging population, and so probably we'll be okay. And,
somewhere along the way, but it'll have to get to be the big crisis before we pay attention to it. I'm surprised, and we've talked, we'll end with this, there is more and more push for prevention. I never heard the word prevention when I was a kid. Other than brushing your teeth, prevent, dental decay, brush your teeth. But other than that, I didn't do anything to prevent anything. And the hope was, whatever happens, there'll be a pill, there'll be a procedure, there'll be a surgery, and I'll fix it. And I go right back to it. I get fat, there's liposuction. I get cholesterol, there's a pill. There's Lipitor or something. There's someday I want a pill to wipe out everything here. But as we get older and live longer and the costs go up accordingly for all this, more and more, I think I'm with Blue Shield or Blue Cross or something here. I'm sorry to say, I don't even remember what I signed up for, one of those two. And more they're saying, hey, why don't you come in and talk to somebody about this? Why don't you talk to somebody about that? Why don't you do a little telemedicine? Why don't you check in more? Here's some other things you might think of. We will reimburse you for a gym membership. Hey, there you go. Other sorts of things. I don't know that we haven't gone far, but we're starting to think ahead. Maybe it's better for us and cheaper for them if we start preventing rather than just trying to cure.
Good. Yeah, good conclusion.
What do you think, Dr.
Thank
Trinh?
you,
Take
Paul.
us out on that. Should we be focusing more on prevention or just on the cure?
Excellent point. I don't remember.
Well, he's having a little trouble.
Yeah, wellness, prevention, preventive medicine. You've heard the word, an ounce of prevention is worth more than a pound of cure.
Yeah.
So we need to detect early memory loss. It is not normal. Progressive memory loss.
It's not inevitable. Let's put it that way.
Not inevitable. Yes, we should not think that this is going to be something that's inevitable, and we can do it with memory assessments, with testing, and especially with the CogniVue devices, which takes the bias out of testing in primary care offices as well.
Well, you put it up on the site, CogniVue, COGNIVUE. Get a view of your cognitive situation here from CogniVue. You can't go buy this yourself, folks. You got to get your doctor to get one, or your pharmacy, or somebody in your health system to get one of these things.
There you go. Yes.
And go tell them, go down to CVS and say, where's your CogniVue machine? They'll say, what?
That's right.
That's what I want my MTV, as we used to say when I was younger. I want my CogniVue.
That's right. Thanks so much, guys.
All right.
Thank you, Dr. Trinh, and thank you, Paul, for this wonderful talk. And I have another call, so I
Yep, we got to go. Thanks so much.
Nice to meet you.
All right. Bye-bye.
Well, there we have it. Another way to improve your life. Longer health starts with cognitive health. You heard it here in Health Talks with Dr. Trinh, right here in Orange County's only community radio station, octalkradio.net. Streaming live from the Cove here at UCI.